There's somebody that had delivered. Oh no, that's our room. Okay, that's fine. Okay. Good morning and welcome everybody. I'm very pleased to welcome you to our live breast cancer tumor board this morning. And a special thanks to the doctors presenting our cases this morning. Dr. Cecilia Espalto is from Centro Médico Espalto in Salto, Uruguay. So she'll present our first case. Dr. Pamela Selman is joining us for the first time from FALP in Santiago, Chile. Thank you, Dr. Selman. And Dr. Vinicius Lorandi and Dr. Pedro Lica are from Instituto do Câncer Mãe de Deus in Porto Alegre, Brazil. I'm sorry about my pronunciation. Thank you. Good morning. And I'd also like to extend a special welcome and thanks to our panelists, including myself, Dr. Paul Goss, Dr. Susan Sager, Dr. Rom Tong, Dr. Jennifer Plichter, all from MGH in Boston, Dr. Carol Marquez from Stanford University Medical Center, Dr. Vera Stearns and Dr. Rasheen Connolly from Johns Hopkins University, Dr. Seema Khan, and Dr. Cesar Santa Maria from Northwestern Feinberg School of Medicine in Chicago, and Dr. Brittany Bishovsky from the Dana-Farber Cancer Center in Boston. So good morning and thank you. Did I miss anybody out? Thank you very much for joining us. Please keep your microphones on mute, as you're all doing now, and that's great, while we are presenting, and only turn it on when you want to speak later in the discussion period. All references or clinical trials cited in this tumor board will be sent to you after the meeting by Jessica. And with that introduction, can we please get started? And I'd like to welcome Dr. Espalto from Uruguay to present our first case. Thank you, Dr. Espalto.
Hi, Dr. Espalto. I think your microphone is on mute. Can you unmute your microphone, please?
Sorry, everybody. Just Dr. Espalto is the first time she's joined, so she doesn't quite know how to get live. Tell me where it is, Jessica.
It's the icon, the second icon at the top of your screen. Looks like a little microphone with a slash through it.
Now, can you hear me?
Thank you. So we're just going to share the cases now, Dr. Espalto.
Okay.
And we can have you present. So if you just wait 1 second. There's our panelist, Dr. Espalto. And there we go. Okay, thank you. Go ahead, Dr. Espalto. Thank you.
Okay. So the case we are presenting today is a 41-year-old premenopausal woman. She had no family history. Her gynecology history, she had 2 pregnancies. Her last pregnancy was 1 year before breast cancer diagnosis. She was breastfeeding at the time of the diagnosis. And in the fourth quarter 2015, she presented with redness, swelling, and enlargement of her right breast that did not improve with antibiotics. So we performed breast imaging that showed an increased thickness of the right breast plus multiple right axillary lymphadenopathies that was BRAF4C. Those are the images at that time. We also performed a core biopsy that showed an infiltrating ductal carcinoma, grade 2, with lymphovascular tumor emboli in the superficial dermis, and it was an ER positive, PR positive, HER2 positive tumor. The fine needle aspiration of the axilla was also positive, and the body CT and bone scan showed no metastasis. So the diagnosis was a breast cancer, T4D, N1, M0, stage 3B, and in the fourth quarter 2015, we began with neoadjuvant chemotherapy with fluorouracil, doxorubicin, and cyclophosphamide by 4, followed by docetaxel plus trastuzumab by 4, and the patient showed a complete remission of clinical findings after the second cycle of anthracycline. And currently, we are planning new breast imaging and whole body CT, and then right radical mastectomy. And after surgery, we plan to complete 18 cycles of trastuzumab, hormonal therapy, and radiotherapy.
Can I, Jessica, Jessica,
Can everyone mute, please?
can you mute your microphone, please?
Yes, of
Can
course.
everybody switch off their microphone, please? Thank you. That's great. So, Jessica, can we go back on screen? So we'll take the questions in a minute. Well, actually, leave it on. Leave that on. I'm sorry, Jessica. So questions from Uruguay are shown on the screen here, and we'll deal with the questions one at a time, if you don't mind, Dr. Salto. So the first question is, if a pathologic review shows residual disease, what is the systemic treatment of choice? So just go back to the panel, please. So maybe somebody from medicine would like to comment. After treating this patient, Susan, maybe you could start by mentioning your choice of neoadjuvant therapy for a stage 3B HER2 positive, receptor positive breast cancer, neoadjuvant chemotherapy, and then is there more back adjuvant chemotherapy in an incomplete remission, so a partial remission but not a complete pathological remission?
Okay, so our standard neoadjuvant regimen here at Mass General would normally contain pertuzumab as well as trastuzumab for HER2 positive patients. I think your choice of chemotherapy was fine. We would normally not use FAC, but I think that's a reasonable regimen. We would normally use AC. The docetaxel or paclitaxel would be acceptable. So I think, you know, if you had the availability of pertuzumab, that would be an addition that we would consider strongly in patients with high-risk disease like this case. There are several other regimens that are routinely used, and I think you can debate who's the appropriate candidate for those regimens. So the TCHP regimen, Taxotere, carboplatin, trastuzumab, and pertuzumab would be another standard combination. I think most commonly in this patient we would have used standard dose-dense AC followed by Taxol, Herceptin, and Perjeta, or the TCHP regimen. Do you folks have availability or access to pertuzumab in Uruguay? No? Okay. So we're spoiled here in the United States in many ways that we have access to some drugs, but not all drugs that you folks do throughout the world. I don't know, Brittany, whether you had other thoughts on the case in terms of initial chemo?
Yeah, so I actually agree with what you're saying. I think one option could be to kind of split the chemotherapy. And, you know, when we would do it here, we would probably do like THP, then have the patient go to surgery, and then do the AC after surgery.
Brittany, could you clarify for the Uruguayans and for me and for everybody, are you suggesting post-operative chemotherapy even if it is a complete pathological remission?
So actually in patients who have node-positive disease, even if we give them THP neoadjuvantly, even if they have a pathologic complete response, we consider AC adjuvantly after their surgery if they're node positive and high risk of recurrence.
And if you use AC in the neoadjuvant setting, what do you do then, out back?
Out back, I think at this stage, I think the chemotherapy that she received neoadjuvantly was appropriate considering that they don't have access to pertuzumab in Uruguay. I think at this point, given how much chemotherapy she received up front, I think kind of the backbone of systemic therapy going forward is going to be hormonal therapy. And because she's young and you know, qualifies for the criteria in the patients included in the SOFT and TEX studies, I would probably do tamoxifen and ovarian suppression or an aromatase inhibitor and ovarian suppression. And I would continue 1 year of trastuzumab therapy.
Do you have a preference between those two, Brittany? tamoxifen or aromatase inhibitor with ovarian suppression or not?
So I don't have a strong preference. I have found that patients who are premenopausal tend to tolerate tamoxifen with ovarian suppression a little bit better than the aromatase inhibitor in ovarian suppression. And I don't think that the added benefit with the aromatase inhibitor ovarian suppression is that much greater. So we often will start people on tamoxifen and ovarian suppression. What's your experience, Susan?
Yeah. Susan, what do you think about that?
So I normally try and give patients what I think is the best treatment and then adjust from there. So normally I would think about ovarian suppression month 1, add an aromatase inhibitor month 2. If they don't tolerate, then I switch to tamoxifen. So that's what I would do. I think the issue of what to do in this particular case if you have residual disease is difficult because we don't have other drugs available. So I don't know if people have followed the neratinib story and whether that may be an option for high-risk patients long-term. So, you know, that study was just published, I think, in Lancet within the last month and looked at after a year of trastuzumab taking high-risk patients and randomizing them to neratinib, which is another HER2-directed therapy, versus nothing. And the patients who received neratinib had more toxicity but seemed to have a better outcome. So long-term, maybe there will be some clinical trial options or additional HER2-directed therapies we could use. I'll stop there.
Thank you, Susan. I might just add about the endocrine therapy. We published a paper a while back that if there's a premenopausal patient who gets ovarian function suppression and tamoxifen, that's the sort of patient without the ovarian suppression that was in MA17. But the fact is that when such a patient became naturally menopausal and was put onto the aromatase inhibitor after the tamoxifen, those are the patients that did the very best of all. So just let me say that premenopausal women receiving 5 years of tamoxifen who became naturally menopausal after the 5 years or during the 5 years of tamoxifen did extraordinarily well after sequencing with aromatase inhibitor. So I think the idea of giving ovarian suppression and tamoxifen, and then if the patient is sort of that age where she's likely to become menopausal, and following up with an aromatase inhibitor seems to be a highly effective therapy and something that I would consider depending on her premenopausal status. That is one of them. The other thing is that at this ASCO, I'll be updating the data on the extended aromatase inhibitor therapy. So we've all known that 5 years of AI is the most common postmenopausal adjuvant endocrine therapy in the world right now, certainly in the United States. But we don't know what the effect of extending endocrine therapy beyond 5 years of AI monotherapy is. And that data is I'm presenting at this ASCO for continuing the aromatase inhibitor out to 10 years. So you'll see that data. So that's another point about endocrine therapy I just wanted to quickly make. I'm making it because I'm in the throes of preparing that presentation now. So let's go to the next question that you had.
Can I make one point here?
Yeah.
Or kind of ask the panel a little bit. So we talk a lot about ovarian suppression, and where I trained as a fellow in comparison to where I am now, I've seen that there's a little bit of a difference in practice, and I was just kind of curious what other kind of groups do, because one thing that I have seen is, you know, and it's, I think, variable. Sometimes when patients are being treated with like Lupron for ovarian suppression, some providers will check estradiol levels in women who are premenopausal to confirm that the dosing is appropriate. And what I have found here, which is different than what kind of like the up-to-date or other guidelines do, is we actually give 7.5 of Lupron, so like double the dose of what the label says. And so I'm curious kind of what other practices do. So we'll do 7.5 on a monthly basis, and occasionally we'll check estradiol levels to confirm that a patient ovaries are indeed suppressed.
So Brittany, can I just say something?
Yeah.
This debate originally started through ovarian suppression for endometriosis and in which Salto's laboratory. And what he showed is 100% of women on Lupron become amenorrheic, but not all maintain persistent estradiol suppression. And there's a slight small, I'm not sure about clinically meaningful, but there's a slight small escape in endometriosis patients in estradiol levels after a period of time on Lupron. So that has resulted in, Brittany's absolutely right, that's resulted in higher doses and more frequent scheduling of Lupron as considered one of the optimal ways to give Lupron. And so I think because of that theoretical problem with Lupron and the escape from its effects clinically, especially in young premenopausal women, even though they're amenorrheic, they should probably receive the more aggressive dosing of Lupron and the more aggressive scheduling as well. I don't know if everybody else. Rasheen, are you there? I can't really see you, but if you're there, can you comment?
Yeah.
Rasheen, thank you. I didn't see you, Rasheen. Go ahead.
Can you hear me now?
Yes, thank you.
We have only been using the standard dose actually here of ovarian suppression, but I concur with what other people have said in relation to using that in this patient post-chemotherapy if she has evidence of residual menstrual function or estradiol. I did want to just comment on one other study that is available for patients post neoadjuvant therapy, which is the Catherine trial. So I wouldn't recommend anything different in the off-trial setting for this patient from a HER2 therapy perspective other than trastuzumab to complete 1 year of therapy. But the Catherine trial is randomizing patients with residual disease to trastuzumab versus TDM1 for a year. So I think the results from that study and then the longer follow-up from the ExteNet study, which was already mentioned, will be interesting. I think the results from ExteNet were only very early, like 2-year follow-up. So it will be interesting to see what longer follow-up shows.
And Rasheen, while I've got you, can you comment on the third question from Uruguay, which is, without a family history, because of her age, would you test for BRCA1 in this patient? She's 41 years old.
Yes, we would test, well, we would refer to our genetic counselors here for any patient with a diagnosis of breast cancer under the age of 50. So yes, we would in general.
I think some people use 40, other people use 50. Brittany, any consensus there? Or Cesar, any consensus about the age?
So I think that NCCN guidelines are 45, saying all women less than 45 should be tested for the BRCA mutation. I don't think a positive result would change the neoadjuvant treatment choice. We are on occasion for patients who have triple-negative breast cancer and are tested positive for the BRCA mutations. We're enrolling them in clinical trials that are investigating the role of
I think Brittany was about to say platinum analogs or PARP inhibitors. Sorry, Brittany, we've lost you. Cesar, do you want to say anything about neoadjuvant chemotherapy in BRCA1/2 carriers?
Sure, yeah. The main question comes up in patients with triple-negative breast cancer and the consideration of carboplatin. Well, that is limited, sometimes in patients with particularly higher risk breast cancers will consider adding carboplatin and mutation carriers. And that's some conversation.
And I think I'm right in saying, Susan will help me, but I think that at MGH, the only time we use platinums is in carriers for neoadjuvant therapy, but not as adjuvant therapy as yet. Is that correct, Susan?
Yeah, that's in general correct. The only other times I've seen it routinely used in patients who have received neoadjuvant AC chemotherapy and who have no response, and then as you're into your Taxol phase, we'll add in carboplatin, but otherwise correct.
Yeah.
Okay, Dr. Espelta, have you answered all your questions?
Paul, can I add something?
Yeah, sure, Veris.
I just wanted to mention, going back to the previous question, that we've just updated the ASCO guidelines to comment specifically on hormonal therapy for the younger women based on text and soft results. So that just came out in JCO. And in general, the recommendation was that in younger women, about 40 or younger, give or take, if the recommendation is for chemotherapy, then we should also consider ovarian suppression. And there is just some mixed opinions between AI and tamoxifen, but the overall consensus was that AI is slightly better compared to tamoxifen. Of course, we did not compare longer duration. We compared only 5 years, and how to weigh that with tamoxifen for 5 or 10 years or tamoxifen followed by AI was not addressed.
And what about the dose of ovarian suppression?
So the dose that was recommended was based on the studies, which is the usual dose, and also in terms of monitoring, we did not feel there was sufficient data to recommend monitoring, although in practice, several members said that they're doing it. We do not monitor estrogen levels in our practice routinely.
I don't think estrogen levels should be monitored because, you know, normally the levels are well suppressed, and the actual accuracy of the level measurements at that level are not within the scope of the average hospital laboratory and really require a research laboratory to be accurate. So I think it shouldn't be done routinely. I think monitoring should not be done routinely. But I do favor the higher dose, I must say, or a more frequent schedule, just because of that endometriosis escape phenomenon that was reported years ago. Okay, thank you very much, Dr. Salto. I hope we answered your question. Now we'd like Dr. Salmon from Santiago in Chile to present a second case. Can you hear us?
Yes.
We're just going to share the slides and you can start presenting as soon as the slides are on. So this is our second patient. Thank you very much. Dr. Salmon, go ahead, please.
Okay, this is a 42-year-old premenopausal woman with no comorbidities. In Q1 of 2015, she had a discomfort in her right breast, and she had a palpable mass. So that's why she came to the practice. Her physical examination showed a 5-centimeter breast mass with right axial lymph nodes. Well, we performed the mammography, which was positive, and then we went to the CT scan of the whole body, and that showed a breast mass of 4.5 centimeters with axillary lymph nodes in the area and supraclavicular lymph nodes. The biopsy performed showed invasive ductal carcinoma grade 3 with ER and PR positive and HER2 negative. So she went into neoadjuvant chemotherapy with 4 cycles of AC and 4 cycles of paclitaxel with a tumor shrinkage of 2 centimeters with no palpable axial lymph nodes. She had no grade 3 or 4 toxicities. So then she went to a right mastectomy with radical lymph node dissection, and the biopsy confirmed the ductal carcinoma with a viable tumor of 1.8 centimeters and 8 out of 20 lymph nodes that were positive. And then she went into completing the therapy with radiotherapy. So our questions here are what to do with this patient in sort of further therapy, which was mentioned before in the other case, but she is HER2 negative, and if all chemotherapy should be completed before the surgery, or we should split therapy.
Okay, thank you for presenting your case. Dr. Gus just stepped out for a moment, so I guess we can open up the first question that Dr. Salmon had. Would anyone like to volunteer an opinion on the best further therapy that is recommended for this case?
I can start if Merit's turns. So in general, we have recommended trying to select women for neoadjuvant chemotherapy that you know are going to require third-generation regimens, and if so, we try to administer the entire regimen prior to treatment. So in this case, she received anthracycline taxane-based therapy. We have not adopted the use of a platinum agent in the preoperative therapy for all patients, but we would consider, so if someone started AC and did not have a robust response, we might add the platinum. I think this is more relevant in the triple negative population or BRCA carrier, and this patient is obviously ER positive. So in terms of choice of therapy, I would probably administer the same regimen, and at this point I would probably maximize hormonal therapy. But one of my questions, I don't know if we have any surgeons today on the call, is about the choice of the surgical operation in this case.
So I don't know if there are any other surgeons, but I'm happy to comment. One question I had, both this case and the last one mentioned that they performed a radical mastectomy, which we don't usually perform here in the United States. We usually do a modified radical mastectomy and spare the muscle. So I wasn't sure if that's just a difference in terminology, or we're actually still removing the pec during your surgeries, which is probably not necessary. For patients with inflammatory, in the first case, I do agree that a modified radical mastectomy is what we would recommend here in the States was appropriate. In this particular case, I do agree that an axillary dissection or radical dissection, as they've referred to it here, is also appropriate. When it comes to a mastectomy versus a lumpectomy, there is some suggestion that patients who have a good clinical response may be able to undergo a lumpectomy, but it sounds like this patient had pretty advanced disease, and I probably would have also recommended a mastectomy. So I think that she did receive the appropriate surgical treatment. Especially with the addition of radiation, though, I again would have said that she probably didn't need a radical, but maybe a modified radical. Mastectomy would have been appropriate. But again, I don't know if that's just a difference in terminology, or if you are actually removing the muscle, which would be what the traditional terminology would imply.
So perhaps, Carol, could you speak up, please, and just talk about the surgery and the local radiation treatment, etc.?
The radiation, it's appropriate that she receive radiation given her initial extent of disease and the residual amount of residual disease that she has after her neoadjuvant. And the nodes, all of the nodal groups should be included, internal mammary, axillary, supraclavicular. This dose fractionation isn't what we would typically use here in the U.S. We would use standard fractionation, giving her approximately 50 gray to all of the nodal regions. I'm assuming that's a hypofractionated regimen that was used, which we don't typically use when we're treating nodal volumes here, but all of the areas were appropriately treated, it looks like.
Thank you, Carol. So, has the chemo question been answered?
No.
Anybody else got some general comments to make about this case? Susan?
I think as I read through this case, I was interested in really how much disease was left. So I don't know whether people have looked at this residual cancer burden and tried to use that to try and assess patients' prognosis after neoadjuvant chemotherapy. Are people familiar with that? I can't really tell, but it's still not in standard practice, but it's been published in reputable journals. We can send around the references. But basically, it classifies how much tumor is left both in the primary tumor bed as well as the lymph nodes after surgery. So depending on what numbers you plug into this equation, this patient either has a really awful prognosis or really maybe it's not so bad. So what if these 8 out of 20 lymph nodes just had microscopic residual disease? That's a much better prognosis than if this patient had really macrometastatic disease in the nodes. So I think going forward, as we think about who is a candidate for more aggressive treatments post-operatively, it's important that we have a clear understanding of how much disease. So that calculator is available online from MD Anderson. So I found it helpful just trying to assess in my brain, what's this patient's long-term risk? How closely should I follow?
Susan, how are you using that clinically at the moment in a patient?
So for right now, for patients who haven't had full chemotherapy up front and are hormone receptor positive, so I had a lady in my clinic this past week that we've had lots of discussions about, had 0.1 millimeters of invasive disease left, started with a 5-centimeter mass. She didn't want adriamycin cytoxin. She had Taxol, so she had paclitaxel, Herceptin, and pertuzumab up front. And so she was a patient who, although standard of care would have been to offer her AC, I didn't feel badly her declining it because she had minimal disease left. So I think her prognosis was better, plus she could still have her endocrine therapy and, finish out her 1 year of trastuzumab. So I think for other patients who have high-risk disease, those are the patients that you really want to try and get into studies if they exist. So I think
just so that everybody's clear, Susan, if a patient has residual disease, you don't routinely recommend further chemotherapy, or you do?
I don't routinely in this kind of case where the patient has really received maximum treatment, but this would be a patient who we would be looking for studies for. And we may view her prognosis enormously different as clinicians and how we counsel these patients going forward if they really have minimal residual disease versus a lot of disease. So I don't know whether anyone else uses that clinically at all.
Any comments from other people?
Paul, I just will repeat what I said when you were out of the room. I tend to try and give the entire third-generation regimen up front, and I would not administer today additional therapy off study.
But sometimes, I think Susan's made the point, sometimes if the patient doesn't get the full neoadjuvant schedule,
Correct.
then you'd complete it afterwards, right?
Yes, yes.
Please let me be clear. You'd complete it if she had residual disease, but you wouldn't complete it if she had a pathological complete remission. Is that true?
Well, as I said, we try to recommend and complete the entire neoadjuvant third-generation regimen up front, if at all possible. If it is interrupted, and she had only part of the treatment and had a PCR, I think it still warrants a conversation. We're treating micrometastatic disease that may be elsewhere, and we know that in general, a third-generation regimen is better than a first generation. So I don't think we have the answer. So I think if we recommended up front a third-generation regimen, that would be my preference. Ideally, with future studies, we'll adapt treatment a little bit better. We have more studies when we might give part of the regimen up front, and then I will definitely complete it after surgery, but I would not add an additional chemotherapy agent off study today.
Thank you. Just to remind people, everybody who's, I'll come to you, Brittany, everybody who's mentioned a clinical trial today, can you please send the reference to Jessica and she'll distribute it to the whole panel, to everybody attending. Brittany, you wanted to say something.
I just wanted a clarifying question. So the patient, it says here, received 4 cycles of weekly paclitaxel. What was that dosed at? Was that the 80 milligrams per meter squared?
Yes. Yes.
Because our standard, just as a note, is we usually do 12 cycles. So I'm not sure if that changes people's thinking about doing more chemotherapy after surgery. I think that's something. On one side, it seems like she has quite a bit of residual disease, but I think, kind of our standard, we would have done AC times 4 and then probably 12 cycles of paclitaxel up front. That said, she got quite a bit of chemotherapy, and maybe she doesn't really have that chemosensitive disease, and that her tumor is more, hormonally driven than other tumors. And then regards to clinical trials, I forget the exact eligibility criteria of the PALLAS trial, but it's studying the role of palbociclib in addition to endocrine therapy in the adjuvant setting. And so that is one trial that we would maybe consider this patient for. I think the criteria is patients who have, more locally advanced ER-positive, HER2-negative tumors.
Okay, thanks, Britt.
Paul, can I make a comment?
Yeah, please, Roisin.
At first, I'm not sure if there's just a bit of confusion about the paclitaxel. I think maybe this was a number of cycles of weekly paclitaxel, and perhaps the 12 doses were given. So that could potentially be clarified. But I just wanted to bring just to mention the CREATE-X trial to the group again. I'm not sure if this was potentially one of the things that was being considered, but this was a study that was presented at San Antonio from a Japanese group, which randomized patients who had residual disease after neoadjuvant therapy to Xeloda for 8 cycles versus no Xeloda. So in that group, actually, there was about 60% of patients were premenopausal, about 60% were node positive, and about 60% were ER positive, and the majority of patients had received neoadjuvant ACT. So I think the results were very interesting. The primary endpoint was disease-free survival, and there was a 6% absolute benefit in terms of 5-year disease-free survival, and a 5% benefit in overall survival. And I think, you know, this is an Asian population. It's not a South American, Central American, or North American population, but I think it's definitely interesting. And it has prompted for one of our post-neoadjuvant ECOG studies to be redesigned to have Xeloda as a control arm. That trial, which is being run by Ingrid Mayer, randomizes patients with residual disease after neoadjuvant therapy to a platinum. It was originally a platinum versus placebo, and now it's going to be redesigned to be a platinum versus Xeloda. So I think once we have that trial open, we'll definitely be enrolling patients in that post-neoadjuvant ECOG study. But in this young patient who has a lot of positive lymph nodes, despite aggressive therapy, I might at least think about the CREATE-X trial in her management, and again, maximize the endocrine therapy, as was already mentioned.
Thank you, Christine. Okay, any other comments about that? We're ready for you, Pedro, and I think we're into Porto Alegre now, the third case of the morning, and if you just bear with me. Dr. Randy is going to present this case. Dr. Randy, can you hear me?
Yes, I can.
Please go ahead, please.
Good morning, everyone. So the case we're doing today is about a 38-year-old female woman who was premenopausal and had no comorbidities. She had breastfed 2 children, had no other family history of breast or ovarian cancer, and had no other known risk factors. She presented in late 2011 with an invasive ductal carcinoma on her right breast, which was a clinical T4, clinical N2. The tumor profile both showed estrogen receptor positive and progesterone receptor positive. The immunohistochemistry for HER2 was undetermined, and then a CISH was performed, which came out negative. The Ki-67 was 30%. So therefore, lumino B-like HER2 negative profile. She then went on neoadjuvant chemotherapy with 4 cycles of doxorubicin and cyclophosphamide, and she only received 3 cycles of docetaxel. That was stopped early due to suspected local clinical progression. She then underwent a modified radical mastectomy, an axillary lymph node dissection, and the pathology report came out with a YPT4, YPN2, with 5 out of 17 lymph nodes carcinoma, and a CM0. Also, the pathology report showed positive margins, and then she underwent radiotherapy for that. I'd like to remind that systemic staging was negative back then.
So that diagnosis of stage 4 breast cancer is incorrect?
No, so there's more.
Okay, sorry. Go on.
Yeah. Right after that, she was put on adjuvant tamoxifen, and only on the second quarter of 2011, she actually came to our institution. All the treatment before that was done in another institution, and it was added gozeralin every 3 months. some 6 months later, in 2012, she developed abdominal pain. Imaging showed an ovary lesion, and she underwent a bilateral salpingo-oophorectomy. The surgery was an R0 resection, and both pathology and immunohistochemistry suggested metastatic breast carcinoma with no residual disease.
Next.
Then, some 18 months later, well, back then she was started on anastrozole as first-line endocrine therapy, which she stayed on for 18 months. By then, she presented bone progression and was put on second-line exemestane and pamidronate. Only 4 months later, there was again bone progression. She was offered radiotherapy and was put on third-line fulvestrant and changed to zoledronate. And again, 3 months later, she had bone progression again and was started on capecitabine. She, at some point, towards the end of 2015, she abandoned follow-up and treatment, and by then, she had been responding clinically and tolerating the treatment very well. So, this year, on the first quarter of 2016, she presented with a large, massive, actually, pleural effusion, some new liver lesions, and some new spine lesions. For that, she had pleurodesis and was again directed for radiotherapy of the spine. And the pathology for the pleura, immunohistochemistry suggested a breast primary origin, and again, a lumino-like HER2 negative profile. She also was found with a new contralateral breast mass, and we conducted a biopsy of that mass, and again, the immunohistochemistry showed a similar profile of her first tumor. She also received radiotherapy for that breast. And it was, after that, we started on capecitabine on the first quarter of 2016. So the questions that we bring today for discussion is what's the impact of the contralateral breast tumor in this scenario?
Can you please mute your microphone?
Sure can.
Everybody mute the microphone, please, except the person speaking. Thank you.
So again, the second question we bring for discussion is if we should restarting chemo with capecitabine acceptable, or should she receive another therapy? And considering that she has a hormonal positive disease and progressed on all approved single endocrine therapies, should we still try to re-challenge her by offering combined endocrine therapies with mTOR or CDK4/6 inhibitors? And also, if there's any role for testing for androgen receptor.
Okay, a very interesting and difficult case. Anybody want to take a shot at that? It's a really interesting but sad case. Anybody want to comment?
Can I ask for a clarification?
Go ahead, Vered.
Was the HER2 initially positive by immunohistochemistry, and was it repeated at any time?
It was 2+. It was indeterminate, and then the test was negative.
And was it repeated on the, there was another specimen, I believe, in ovary, perhaps? Was it repeated?
Yes, the ovary was repeated, and it was also negative. Immunohistochemistry.
Montevideo, can you turn your microphone off, please? Montevideo. Dr. Espelto, can you turn your microphone off, please? So, Brittany, do you have any insights into this case?
Sorry, my microphone was off for a moment. So I think this is a patient who's had a lot of treatment so far, and probably, it seems like she's had disease progression despite multiple lines of, endocrine therapy and then also targeted therapy with the exemestane, and she received capecitabine too. So I think, she's coming to the point that we have to be creative at coming up with a good option for her. If she was here, I would consider enrolling her in a clinical trial. And I do think, you know, there are some interesting trials now with the androgen receptor that are available. I would also think that she could be a good candidate to treat with palbociclib in some form. You know, I don't know if that's available, Pedro, in Porto Alegre, where you guys are at. But regarding, you know, next steps, you know, I think it's you know, I think you could do hormonal therapy and then add on something else, depending on her, like, you know, symptoms. Now, you could do more chemotherapy. You could try something like single agent Taxol too.
Pedro, maybe I could just make a comment. You know,
Sure.
we are about to launch a study of, there are 6 countries out of 47 in South and Central America and the Caribbean that have legal patient directive legislation on the national judiciary. So that means only 6 countries can patients sign a do not resuscitate type of order. And the number of patients that actually does that, Mexico was one of the first countries where patients could sign, and only 600 patients in a population of 100 million or something in Mexico signed that in 2015. So there's tremendous room for improvement of, and we've also just published on the expansion of palliative services in South America over the past 2 years since we are first commissioned to our second commission. So there are an increasing number of hospitals that have palliative care for stage 4 patients. And there are 6 countries, as I say, who have patient directives to be signed legally, but very few are doing it. So I would encourage everybody to involve palliative care services, if you have such a thing, early on in the course of stage 4 disease. I sort of view it like a team of 10 people, and 8 people are active treaters and 2 people are palliative treaters in the beginning, and toward the end, 8 people are palliative and 2 people are active. So you have a mixed team that follows the patient and cares for the patient all the way through. And this patient strikes me. Carol, I don't know if you want to comment on that radiation on the spine, but that's part of her palliative care. But I think this patient is a key candidate for palliative care now, despite there being clinical trial options for her available, perhaps. That's my own view. I mean, I think that the whole topic, there have been recent publications, and there's one coming out in the Lancet, of expansion of palliative care services in South America. And I would, not just in oncology, but in all branches of medicine. And I would strongly urge everybody on this meeting today to read up about where the palliative services are and what they are in South America, because clearly they are being currently underutilized.
The other thing I would point out for this patient is she's quite young, and I know it may not matter for her, but she should probably have genetic testing, especially now that she's had a bilateral breast cancer. So something that she could probably be tested for, since she does have 2 children and probably other family members that might be at risk.
Yeah.
Most definitely. We actually referred her for BRCA1 and 2 testing already, but the results haven't come out yet. She has 2 daughters. So.
Okay.
Can I ask what, this is Roisin here, can I ask what targeted therapies you do have in this space available to you?
We have everolimus that we could combine. We still don't have palbo available here in Brazil. It's pretty difficult to get. But we could do some sort of hormonal therapy with everolimus, or maybe change the chemo or try Xeloda a little bit more. I don't know. That's the doubt.
Yeah, so I'm just wondering, her period of time on tamoxifen was pretty brief. I'd say she probably already had metastatic disease at that time. So, whether you could combine tamoxifen with everolimus per the phase 2 TAMRAD data as one option if she wants to have therapy. However, I fully agree with Dr. Goss that for this type of patient with very widespread disease, multiple issues, and less and less treatment options, that a focus on supportive care may actually help her to live longer and better than giving her different treatments.
Right. The other thing, Pedro, I wanted to mention, she got permidronate by mouth initially for bone metastasis, which is an old-fashioned English treatment. But it's clear now that zoledronate is better. So can you give it earlier in the course of disease?
Yes, yes, we can.
Because I think since it's been used, we've seen almost no hypercalcemias, almost no spinal cord compressions. A lot of the old complications of bone metastases that I used to see when I was back in England many years ago have been eliminated by the use of zoledronate. So it's a really effective drug for palliation purposes, I think.
Let me ask you something, Paul. When you have a patient on zoledronate and she has bone progression, do you think of changing her to DMAB, or do you maintain her on zoledronate, or what's been?
Let me ask the others to comment. Susan, what do you think about that? What do you give after zoledronate progression in bone?
Yeah, so those patients I've switched to denosumab. I feel like it's a different mechanism of action, and it seems to help the patients clinically. I don't continue to hear of a lot of bone pain from those patients going forward. So that's typically what I do. And then I would normally start with denosumab rather than zoledronate in patients with renal insufficiency.
Right.
And part of that is the cost of the drugs.
Anybody else got an opinion of zoledronate against denosumab? Brittany, what do you think?
So I agree with what Susan said. We tend to start with Zometa, and if patients have disease progression, then we will make a switch. I think it kind of depends on how they're doing. So we often won't make that switch immediately at the first time the patient has disease progression, but maybe the second time or the third time when we're also making a change in therapy if the patient's symptomatic.
So I think we're right on time for our 3 cases. Does anybody have any comments about any of the cases, or the third case in particular? Any comments from the panel?
I have just a comment on this last case, and I realize that palbociclib is not available, and also it's not on label for this patient, but just to comment that, we're participated in the expanded access protocol, and there are some patients who have had, who received multiple line of hormonal and chemotherapies and have been on palbociclib for over a year. Now, I don't necessarily think she's would be one who would benefit, but I think that there will be more studies looking at the CDK inhibitors in later stages, and it'd be something worth looking into.
Right, thank you. Okay, well, with that, if nobody else has got a comment, I'd like to say thank you very much to all the panel and all the people presenting cases today, and all the attendees. Thank you very much. Bye now. We're going to sign off.